आज हमारे साथ है डॉक्टर अजय शर्मा सर, डेंटल सर्जन। आपका डे कितना डिफिकल्ट होता है?
Dental surgery is not an easy field. Dental surgery is one of the complex field.
डेंटल मुझे सर्जन बनना है rather than other fields।
बड़ा वैक्यूम है डेंटिस्ट्री में जो अभी तक पूरा नहीं हुआ है।
कौन से चैलेंजेस है जब हम कन्वेंशनल इम्प्लांट यूज करते हैं?
You do not get ideal bone topography.
आज हमारे साथ है डॉक्टर अजय शर्मा सर, डिपार्टमेंट ऑफ डेंटल साइंस एंड मैक्सिलोफेशियल। ही इज वर्किंग विद मैक्स हेल्थ केयर। ही है ऑल्सो 30 ईयर प्लस एक्सपीरियंस इन डेंटल साइंस, मैक्सिलोफेशियल सर्जरी, डेंटल सर्जरी, एंड ही हैव डन MDS प्रोथोडोंटिस्ट इन किंग जॉर्ज मेडिकल कॉलेज लखनऊ, and also he had done many dental implant surgery successfully in his career। dental surgeon, आपका डे कितना डिफिकल्ट होता है मैनेज करना?
फर्स्ट ऑफ ऑल बहुत सारे लोग का एक परसेप्शन है अबाउट डेंटल सर्जरी कि डेंटल सर्जरी एक ईजी फील्ड है। आई थिंक वी हैड अ डिस्कशन, डेंटल सर्जरी इज नॉट एन ईजी फील्ड. Dental surgery is one of the complex fields, and when I started with dental surgery, dentistry was in a very infantile stage in India. I joined Maulana Azad Medical College. He used to have a dental department there on the 4th floor in BL Taneja block, and very small department. That time, we didn't have a separate dental college like we have a full-fledged dental college now at the same place. I did my bachelor's, started my bachelor's in 98 and then finished in 1993. I'm proud to be one of the Maulanians and initial stages, and that time people used to avoid taking dental surgery. Let me tell you a very interesting thing, that my rank was very good. I could have chosen MBBS in Maulana Azad, but somehow I always wanted to do dentistry, and the same footprints had been followed by my son. He was topper in NEET, and now he did his BDS from Maulana Azad, same college, and he's doing MDS from AIMS. Interestingly, dental sciences has come long way in last 30 years, and I have seen tremendous growth in terms of newer equipments, newer technologies, newer colleges. The students have so much to learn today. In our times, we had so many limitations, and in those limitations, we did our best, and here we are.
वो मोटिवेशन कहाँ से आया कि एज ए डेंटल मुझे सर्जन बनना है rather than other fields?
बहुत ही इंटरेस्टिंग क्वेश्चन है माय फ्रेंड। मेडिकल कॉलेज पहुंचा फॉर काउंसलिंग जब मेरा रैंक बहुत अच्छा था, और जब मैं पहुंचा तो वहां पर डॉक्टर टंडन, हु वाज वन ऑफ द प्रोफेसर्स इन एनाटमी, he met me, he asked me, I asked him, sir, I've come for the counseling, where should I go? उन्होंने पूछा, बेटा आपका क्या रैंक है? I said, sir, this is my rank. He said, आपको easily मौलाना आजाद मिल जाएगा MC में, कोई प्रॉब्लम नहीं है, and you will get MBBS. बट एक चीज़ बोलूँ, he said this to me. मैंने कहा, हाँ सर बताइए। मेरी एक सजेशन, आप डेंटिस्ट्री करो। मैंने कहा, सर बट डेंटिस्ट्री का तो इतना स्कोप नहीं है और इतना क्रेज नहीं है, मैं तो शुरू से MBBS करना चाहता था। मैं सिर्फ इतना कहूँगा कि मौलाना आजाद में मेरी अपनी बेटी 3rd ईयर में बैचलर ऑफ डेंटिस्ट्री कर रही है इसी कॉलेज में, तो आप ये समझ सकते हो कि कितनी इंपॉर्टेंट फील्ड है और कितनी तेजी से आने वाले 25 साल में ये मार्केट को रिवोल्यूशनाइज करेगी और डोमिनेट करेगी। और एक बहुत बड़ा वैक्यूम है डेंटिस्ट्री में जो अभी तक पूरा नहीं हुआ है, और यू विल बी द पायनियर व्हेन यू डू दिस, एंड दिस इज द राइट टाइम टू गेट इनटू डेंटिस्ट्री, एंड दैट वाज द चेंजिंग पॉइंट, एंड ही वाज अ पर्सन हु मेड मी पुश फॉर डेंटिस्ट्री, और फॉर डेंटिस्ट्री another push. He made me opt for dentistry, and I'm really sincerely thankful to him, though he is no more, and but his daughter is there, and she's one of the finest practicing oral and maxillofacial surgeon in US.
ऐसे कौन से चैलेंजेस है जब हम कन्वेंशनल इम्प्लांट यूज करते हैं? कौन सी डिफिकल्टीज है जो एक सर्जन फेस करता है ड्यूरिंग द कन्वेंशनल इम्प्लांट यूजिंग?
देखिए, सबसे बड़ा इशू कन्वेंशनल इम्प्लांटोलॉजी का आज भी ये है, यू डो नॉट गेट आइडियल बोन टोपोग्राफी। हर पेशेंट सेम नहीं होता। समटाइम्स यू गेट गुड वॉल्यूम ऑफ बोन and you can operate and you can put conventional implants in a very simple way, but most of the cases today which we get are severely resorbed maxilla, mandible, and patient have only what left is only the basal bone. Most of the alveolar bone is resorbed, and उन केसेस में conventional implantology becomes very difficult, क्योंकि पेशेंट के लिए, डॉक्टर के लिए उधर ऑपरेट करना या फिर उस एरिया को ऑगमेंट करना एक अपने आप में चैलेंज है। टू ऑगमेंट यू नीड बोन फ्रॉम डिफरेंट साइड्स, और यू नीड पेशेंट स्पेसिफिक इम्प्लांट्स। पहले ये प्रोविजंस नहीं थे। पहले हम लोग बोन हार्वेस्ट करते थे फ्रॉम द डोनर साइड्स, और फिर उस डोनर साइड्स की अपनी मोबिडिटी होती थी, चैलेंजेस होते थे, और उसको प्लेस करना, फिर सॉफ्ट टिश्यू से कवर करना, फिर उसके ऊपर उसका एक्सपोजर होना या रिजेक्ट होना. These complications were much higher earlier, which are not there today. So conventional implantology cannot do everything. So you need more complex management of. For the more complex cases, you need more patient-specific implant and more complex implantology. And today, luckily, we have those provisions. We have, all the infrastructure to make PSIs or the complex do the implant surgeries easily with precision and with ultimate outfits, a remarkable outfit, pre-predicted outfits. We know what exactly we will be giving to the patient. हम patient को दिखा सकते हैं what exactly will be the end. And he should know, and the surgeon should also begin with the end in mind. And patient should know, it is the patient's right to know कि मेरा ये look आएगी या मेरा ये final outcome होगा, जो आज हम virtual planning से कर सकते हैं, और वो outcome हम patient को दिखा सकते हैं, and we can execute the same thing what we plan.
Of course, sir, we can show the patient what would be the outcome after the surgery using advanced softwares and models. सर, आप अपना फर्स्ट एक्सपीरियंस शेयर कर सकते हैं, इफ़ यू रिमेंबर व्हाट काइंड ऑफ चैलेंजेस व्हेन यू यूज ए PSI implant?
See, I tell you something. I started doing implants in 1996. That was last century. So you can imagine.
Oh.
So 1996 I placed my first implants. और उस समय conventional implantology अपने आप में एक बहुत difficult segment होती थी. Forget about PSI. We had, blade implants were there already in use, but उनकी भी अपनी limitations थी, उनकी अपनी, उनको they were prefabricated. Subperiosteal implants को आप impression लेते थे और फिर डिज़ाइन करते थे, और कई बार वो फिट नहीं करते थे और आपको डबल, इंसिजन देना पड़ता था. मीन्स पहले आप इंप्रेशन लेने के लिए खोलते थे बोन को, फिर बंद करते थे, और फिर जब पेशेंट दोबारा आता था सबपेरिस्टल इम्प्लांट दोबारा उस वूंड को खोलते थे और सबपेरिस्टल इम्प्लांट को इंसर्ट करते थे. और उसके बाद मतलब पेशेंट के लिए बहुत लिमिटेशंस थी उस समय. देयर वाज नथिंग एल्स अदर देन लिमिटेशंस. Implantology was in very, very infantile stage. So what I want to share here is that since I'm attached with hospital, with Max Hospital from year 2000, and it's almost now 26 years with that hospital, and we have seen tremendous growth in terms of today we have multiple Max group of hospitals in entire Delhi NCR, and I'm proud that I'm associated with that group since inception, from year 2000. And what I've seen is, initially we used to, sometimes we used to get cases of trauma. We used to get cases from oncology to manage the post-surgical rehabilitation, and sometimes people with congenital defects. तो उनको मैनेज करना हमारे लिए बहुत बड़ा चैलेंज रहता था, और हमारी लिमिटेशंस थी, और हम लिमिटेड वे से ही उनको मैनेज कर पाते थे. I tried some subperiosteal implants, I tried some basal implants, not basal, I tried some blade implants, I tried some ramus frame implants, and did surgeries. The results were not to the perfection, and there were some limitations always. What as a surgeon or as a prosthodontist I used to anticipate, I never used to get that 100% precision, and there were some discrepancies, and there was a lot of time spent in terms of manufacturing or milling, or you can say of the processes. There was a lot of lab support involved, and that labs also had their limitations. My first case of PSI goes almost 10 years back, and that time we made our first patient specific implant not in India. We got it manufactured in Israel. Okay. So there was one company, I don't want to name the company because it is no more in country. So we sent to their manufacturing unit in Haifa, and they made that PSI for us. And luckily, that was my first case of PSI, and it fitted so well, and that patient still comes and meets me.
And which steps of reconstruction surgery are the most challenging to perform a surgery accurately?
See, planning of the surgery is altogether different, but execution of the surgery is the biggest challenge for a surgeon. You plan, but you cannot execute. But today, that challenge is not there. You can execute your surgeries to the core precision with the help of, guided planning, with the help of the softwares. You can design your guides. You can prefabricate your processes, and you exactly know what will be the final outcome. So as you said, what is the biggest challenge as a surgeon you face? It is always, reconstruction, which is the biggest challenge for the surgeon. Resecting, cutting, is not a problem. But rehabilitation, reconstruction is always a problem for the surgeon.
Also, PSI, like you said, PSI guides very useful during the surgery. I think so. PSI very reduce OT time also. We need to plan 2-3 hours how much cut, which angle, and drill, where is the location of drill. So I think so guide will be help in this procedure.
Guide is not helpful. Guide is very helpful. Today, my guide are precise to the core. My result absolutely matches what I plan for. The positioning of my guide is perfect and the fit of the guide is perfect. The post-op morbidity of the patient is very less. Post-op complications are very less. The final outcome is brilliant. So all these things are possible only because of, we have the planning softwares, we have the milling machines, we have the 3D printers integrated with them. So you can plan, print, mill everything today, and you can do your orthognathic surgeries, you can do your reconstructive surgeries, you can do your pre-prosthetic surgeries, you can do your mid-facial defect surgeries, you can do your trauma surgeries, you can do your good extensive maxilla and mandible surgeries, you can do TMJ reconstruction surgeries with the help of these patient-specific implants.
Thousands of successful surgeries already की है. तो एज ए पेशेंट का कंसर्न क्या होता है जब वो रिकन्स्ट्रक्शन सर्जरी के लिए आपसे मिलता है? उसके लिए मनी मैटर करता है या आउटकम्स मैटर करता है एज ए एवरेज ऑफ द एवरेज पेशेंट?
So let me answer this question in two parts. There are two types of patients which come from good socioeconomic status, and some people come from average or low socioeconomic status. But coming them from different socioeconomic status, they should not be deprived of the treatment. But unluckily, I tell you, most of the surgeries which are happening in our country, the reconstruction is not planned along with the surgeries. And I always, assert to the oncosurgeons, maxillofacial surgeons who are operating, please pre-plan your reconstruction, because that's the biggest challenge for the patient. Because once the surgery is successful, the biggest limitation for the patient is to, getting socially, accepted. He becomes socially crippled. He cannot go out with those limitations, with those defects. He has a biggest phobia whether people will mock him, whether people will make fun of him, or people may, even if not in front of him, they will mock him. And this is very common. And they come and tell and they confide in me and they literally cry. Doc, I want the same face, I want the same profile, I want the same smile. And it is, as a rehabilitative surgeon, it is my moral duty to give them their same smile. And this is what, the biggest concern the patient has. Will, after the surgery, my looks be same or will be close enough or good enough that I can socially move around?
सर, जैसे आपने बताया कि जो ऑन्को सर्जन्स होते हैं, मैंने भी बहुत सारी सर्जरी अटेंड की है अपने करियर में, तो मैंने देखा है वो बहुत ज़्यादा बड़ा कट लगा देते हैं आफ्टर दिस कट, एंड दे नॉट इंक्लूड ओरल सर्जन फॉर द प्लानिंग. तो एज ए ओरल सर्जन को जब पेशेंट आपके पास आता है आफ्टर उनको सर्जन, एज ए ओरल सर्जन कितना डिफ़िकल्ट होता है उस पेशेंट को रिकन्स्ट्रक्शन सर्जरी करना, बिकॉज डॉक्टर ने बड़े कट लगा दिए, फ्लैप्स लगा दिए विदाउट ए ओरल सर्जन को इंक्लूड किए बिना. आपका इसमें मतलब क्या?
See, doing surgery, rehabilitative surgery at the same time is very, though it's time consuming. Average surgery, if it is 4 or 5 hours, when we do reconstruction, it is double the time. But definitely, the final outcome is good. और मैं बार बार सबको यही एजर्ट करता हूँ, सारे maxillofacial, craniofacial सर्जन, प्लास्टिक सर्जन्स, ऑर्थोपेडिक सर्जन, ENT सर्जन्स, सबको यही बोलता हूँ, any surgery which you are doing, please think of rehabilitation. Because rehabilitating the patient post-surgically becomes very, very difficult. The results are compromised. You cannot give the same aesthetic results, same functionality to the patient, because there is an arbitrary planning later on which is not precise. You can plan your resection before and you can plan your 3D implant before. During the surgery you can place that same implant made of titanium or PEEK, and patient can have a wonderful profile, rather than later on executing the second surgery, which is very, very difficult because of the scar tissue, because of the flaps, and so many limitations are there. And above all, patients fear for going second surgery again. That is another big limitation which we face.
Sure, sir, I understood. I agree with you. Sir, how do virtual surgery planning important in complex surgery?
See, without See, virtual planning is the key success today. If you're not virtually planning your surgery, you spend, let me put it other way. When you do conventional surgery, you spend a lot of time on the surgery during the surgery. In virtual surgery, you are actually spending a lot of time in the planning in the software. So there is a lot of myth that when you're doing virtual surgeries, planning, your time is less. No, you spend money on software. You spend your time on planning, but that's a healthy investment. Earlier, we used to spend more time in the execution of the surgery, and we may not be able to execute it as per our mental fit which we used to plan. So virtual planning is very important. You are aware what will be the end, what will be the final result. Patient also knows what will be the end and what will be the final result. So virtual planning makes you a good surgeon, and you begin with the end in mind, and patient knows what will be the final outcome of his surgery. His family is happy, he is happy, and when you give them. Another thing, I believe in one thing. Anything conveyed to the patient before treatment is a part of treatment plan. Anything after is an excuse. So there are no excuses. You should thoroughly and meticulously plan, and pre-planning with a virtual, your brilliant softwares we have. And there are some paid software which you can buy. If you don't want to buy, you can go online, you can use and pay for the clicks, for the usage of the softwares. There are companies which can, if you don't have a milling unit or a printing unit, you can outsource it to a lab. There are beautiful companies who are doing excellent job with brilliant infrastructure. You don't have to buy everything today. We have those privileges. So plan it, and you send it to the lab or to the company manufacturing unit. They will mill it for you, they will sterilize it for you, they'll give it to you, and you can execute your surgeries with their support.
Sir, अभी का PSI market किस तरह से आप देखते हैं?
It's a beautiful question, and I from last almost 10 years I am talking about the patient-specific implant. Let me tell you, patient-specific implant will come big way, and let me take it other way. Say, suppose you extract a tooth. You extract a canine. You don't have to do anything. You extract, you scan. Once you scan, you have an intraoral scan of the patient, which has the STL file. You have the CBCT, the cone beam CT of the patient, which gives you the DICOM file. You integrate those files, and you can, in the software, plan and mill your dental implant of titanium, of zirconia, or whatever material the future is. And it will be absolutely fit of your socket. You can implant that customized implant of the patient in the canine itself. If you have extracted a canine, it will fit to the core, and that is the future we are looking at. This is what is the future of patient-specific implant. Patient-specific implant are not limited to only teeth. They are involving maxilla, mandible, TM joint, mid-facial reconstruction, orbit reconstruction, what not. You can do everything. You can do pre-prosthetic surgery, you can make subperiosteal implants. So everything is possible with PSIs, and that is not the future, rather it is the present. And I see this industry coming up in a big way. And the way the 3D printers, I forgot this, the way the 3D printers are coming in the market, things are revolutionizing. And in fact, I was with one of the premium companies launch, and they are launching their premium 3D printers. I'm sure you're aware of Stratasys.
Yes.
And they have beautiful printer, and I think they are the leaders. Again, an Israeli company, and they make marvelous printers. And they were talking about some brilliant printers they have launched in the market. So future is very bright of PSI, and I wish all the people, all the surgeons, all the manufacturing units, all the all the industry people who are associated and working for PSIs, I wish them good luck, and I really congratulate them, and I really appreciate their efforts.
इंजीनियरिंग, मैन्युफैक्चरिंग हो गया, टेक्नोलॉजी हो गया, प्लानिंग हो गया, एज ए सर्जन या क्लिनिकल में एक इंजीनियरिंग का कितना इम्पोर्टेंट रोल है?
See, as a clinician, मैं अपनी डिमांड अपने चैनल पार्टनर्स को बताता हूँ. Who are our channel partners? Our channel partners are the bigger companies who are working with medical and dental industry or maxillofacial industry. They do a lot of R&D, they do a lot of investigations, research, and they are the people who, we create demand for those things, and it is those, engineering support or technical support or industry support which are, developing these things because we as a clinician need them. And in totality, it is for the greater interest of the humanity, greater interest of the patient, greater interest of the medical field, that these companies hand in hand work with clinicians. And without engineering support, without technical support, no field can grow. Nobody can grow. If we think that healthcare is rather, one of the fastest growing field, and thanks to our, industry partners, our engineers, our technical support people, our technicians, who are the backbone of everything.
सर अभी मोस्ट ऑफ द केस आप किसके करते हैं PSI में, लाइक मैंडिबल हो गया, मैक्सिलर?
Maximum cases today, if you say, are maxilla.
Maxilla. It's kind of bone loss case or reconstruction.
I tell you the reason for doing more of maxilla is that maxilla is one bone which resorbs much faster, and especially the posterior maxilla. So we have very deficient bone in posterior maxilla, and patients sometimes, cannot. Initial stages they ignore because of periodontal disease. Periodontal disease are a big problem in our Indian market, and people, don't visit dentists regularly. Rather, I have seen people who are very well off also. They avoid visiting dentists initially, and they don't want to consult a dentist till the time they're in bad shape. Today morning also we operated one case coming from a very good family, but socially not visiting the dental surgeon, and we had to do. Though we did all-on-4 surgery because we had very limited bone in intersinus region, so we did that. But sometimes we don't get any bone at all, so we have no choice other than going for PSI, or because that makes more precise surgery for the patient, less post-op morbidity, less pain for the patient, better outcome and greater outcome.
Sir, generally PSI take little more time compared to conventional implant, because we can use conventional implant take from the inventory, because if we are going for the PSI implant, we need to approximate 5 to 7 days. This kind of problems faces generally, sir.
See, anything which comes with precision definitely has to take time, and this is one of the limitations of PSI. Planning and execution. Planning, first you have to meticulously plan, then you have to discuss with your technical team. They will mill it or print it, and once they mill it and print it, definitely they also, if you have to implant that process, it has to be sterilized and packaged for OT usage. The guides, they have to be, sterilized, they have to be used in the OT, they have to be, the material has to be of that par level. And so all these limitations are there, but I don't call them limitations. Any good planning, if you make a good house, there are two options. Either you buy a ready-made house, you get into it, put your furniture and get into it. And today you have everything. You can buy, you don't need to buy even furniture. A good developer can give you a ready-to-move-in house. But when you customize your house, you develop things according to your taste. You do automation, you do VRV, you choose the furniture as per your need. It takes time. Similarly, PSIs. If you're making a PSI for a better outcome of the patient, the two big limitations, the cost also is compared to conventional implant is higher. This is one of the fact. And turnaround time, the TAT, is higher compared to a conventional implant, because conventional implant, we have a stock inventory. Even if we don't have a stock, we can, ask, and overnight we get the delivery. But for PSI, definitely TAT is 5 to 7 days. But I believe this TAT will, slowly shrink. And I'm sure with the technical support and the technical expertise, the way we are going, this TAT will be 2 to 3 days, which is fairly decent.
PSI India में आया था. It will be take 3 weeks, 4 weeks.
So today we are very competent now. See,
it can be complete within 1 week.
Absolutely.
And sometimes in 3 days.
Yes, absolutely. I'm looking at that. 72 hours is not bad. If in future, maybe in a year or two, we'll see that these PSIs will be delivered on your table within 48 to 72 hours. So that's a good time.
और सर, इंडिया की जो हेल्थ केयर इंडस्ट्री है, वो PSI को भी बहुत रैपिडली अडेप्ट कर रही है. अपकमिंग 2-3 ईयर्स में क्या फ्यूचर होगा इंडियन क्लिनिकल हेल्थ में, क्योंकि बहुत फॉरेनर्स पेशेंट भी इंडिया को अप्रोच करते हैं फॉर द हेल्थ. सो कैसे हम देख सकते हैं 2-3 ईयर्स में आने वाले अपकमिंग में PSI इम्प्लांट्स के बारे में?
मैं इसको इस तरीके से आंसर करूंगा. जो मेडिकल और डेंटल टूरिज्म है इंडिया में बहुत अच्छा है. because we are one of the strongest country in terms of medical and dental tourism. And since I'm associated with a corporate hospital, we have our international team who have their base offices worldwide in different parts of the country, in the Middle East, in Europe, UK, US, African countries. So all the continents we have people, and they are, routing these patients to us, and they look up to us, and their expectations are very high because the Indian doctors worldwide are treated as one of the best doctors. Our doctors going in US, Canada, Europe are the best surgeons. You all know that. There is no challenge in that. There is no if and but in that. We as an Indian are one of the finest surgeons worldwide. So people coming to India, they will grow exponentially. People coming to India for conventional implants or PSI implants is already in a big number, and this number will grow tenfold. Let me read my lines. This number will grow tenfold. We have not yet started the actual implantology. We have not yet actually started the patient-specific implantology, if you ask me. It is just the tip of the iceberg. A best is yet to come. The future belongs to us. Future belongs to India. We have to be $1 trillion economy as Modi ji vision. So we will be $1 trillion economy, and healthcare will play a major role.
ओके सर, जैसे आपने काफ़ी सर्जरी की है, क्या कहना चाहेंगे PSI इम्प्लांट और कन्वेंशनल इम्प्लांट को लेकर?
मेरा सबसे पहला कम्युनिकेशन एक बिगिनर को या एक नए कंसल्टेंट को जो अपनी प्रैक्टिस में घुस रहा है, उसको सबसे पहले ये ध्यान रखना होगा कि उसकी बेसिक कंसेप्ट्स शुड बी वेरी स्ट्रॉन्ग. नंबर 1, आज जो कंसेप्ट्स हैं वो बहुत वीक हैं. कंसेप्ट्स सिर्फ AI से नहीं बन सकते. कंसेप्ट सिर्फ डिजिटल वर्कफ्लो से नहीं बन सकते. योर एनालॉग प्रिंसिपल्स शुड ऑलवेज बी देयर. योर एनालॉग लर्निंग विल नेवर गो. You should be, well versed with all your analog principles. Then only you can execute your digital planning. Then only you can be a good, digital surgeon. What I want to say here is that you need to be actually a good clinician with a freehand surgeries before executing these complex surgeries using PSI implants. A lot of people think that we will design it, we will fit it. No, I again, differ here. I may be wrong here, but trust me, it needs more precision. It needs more, meticulous planning. It needs more expertise. So people have a wrong notion that these patient-specific implants or these guided surgeries are easier. No, you need to be a good surgeon first, and then you should go for these complex surgeries. So this is my suggestion to these beginners or these surgeons. Please improvise yourself, learn, relearn, unlearn, and learn newer things. Travel worldwide, execute good things. There is no dearth of teachers in the world. There is no dearth of learning concepts in the world, and there are so many institutions, so many good clinicians worldwide. Go to them, learn from them. In India itself, there are so many clinicians. Learn from them. Don't try to be impulsive to start your own clinics or your hospitals or your surgery or surgical centers. Spend some 5-10 years with good surgeons, operate in some good hospitals, and then you should jump into these type of complex maxillofacial surgeries.
Thank you sir for your advice. Sir, अपना टाइम देने के लिए thank you so much.